So I've entitled my talk, Diabetic Foot Beyond the Dogma. So then, does anybody know what dogma means? Anybody know what dogma means? Belief? Actually, not just belief. You know, there's belief, like I can have belief that my wife's going to cook me a nice dinner tonight, but there's got to be true belief that, you know, she's going to cook me a really nice dinner tonight, okay? And dogma actually is originally derived from religious, almost religious zeal about something. So you really, really believe in it. And the problem with, I think, medicine is there are lots of things in medicine that we really, really believe in, right? But when you start to scratch beneath the surface and you look at the evidence, there's lots of things that are deficient. And hopefully what I'm going to try to give you is not the textbook answers, but the kind of real answers. Okay. So these are my conflicts. Dogma. So here's the definition, official definition of dogma. It's actually a belief or a set of beliefs held by a group of or organization which others are expected to accept without argument. And it's a little bit like the debate that I'm going to have with Dr. Faruqi, where he's going to have a dogma, and I'm going to challenge that. Okay. So, for the diabetic foot, it's a big kind of area and field, but I believe that there are actually 3 areas where we really need to be up to date and we need to practice to the best of our ability. And that is foot ulceration, which will occur in up to 15% of any of your diabetic patients in their lifetime. Osteomyelitis, which won't occur in 15% of patients with diabetes, but 15% of people with a diabetic foot ulcer. So this is always in the back of your mind. You have to think this is not an uncommon circumstance, particularly I think in Pakistan actually, where you do have chronic untreated infections, which actually by the time they present to you will already be osteomyelitis. And then this condition called Charcot foot, which I must say, when I was practicing in Manchester, we saw, and you know, we had made a big deal out of it, but here in the Middle East, I'm seeing a lot more. So I don't know what the situation is in Pakistan. Maybe there's more Charcot, right? So definitely we see much more here. And I think part of that is, again, late diagnosis and, you know, people who don't know they've got neuropathy. So what I'm going to consider is actually evidence-based in terms of diagnosis and management of these 3 conditions. And this is obviously the diabetic foot. So I always, honestly, when I want to know what to do, I look at the evidence, right? So what is it, rather than, you know, you can sit here and you can say, oh yeah, Professor Malik, whatever he says is the truth. No, it shouldn't be that way, right? You should look at the evidence and you should say, you know, this guy's talking rubbish, right? He's talking rubbish because he believes in the dogma, but he doesn't know the evidence. So what you should always do is look at something I think which is an excellent way to do it, is look at the Cochrane Reviews, right? If there's been a Cochrane review done on a subject, then they have spent almost 2 years looking at the evidence. I know that because we're just in the middle of a Cochrane review on something, and it's taking forever, right? So the Cochrane, so these are currently the ways we would manage this. So people say, well, educating people with diabetic neuropathy will help in the management of diabetic foot ulceration. In what way? So education, it is said that if you take a diabetic patient who's at very high risk of a foot ulcer and you give them education, you talk about the risk of having a foot ulcer, and you say to them, you know, you need to offload, you need to do this, it helps prevent foot ulcers, okay? And we believe that. Then, debridement. Is there any evidence that if I take this wound here and I put a scalpel to it and I remove tissue, does it help healing? Right? Improving blood sugar control. See, who believes that improving blood sugar control in the setting of a patient with a diabetic foot ulcer will help them in terms of their healing? Yes or no? Good, right? I'm glad you say that, because actually the evidence is very limited, right? Yes, somebody who's toxic and has very, very high sugars, you bring down with an IV infusion, will probably be better in terms of their immediate, probably mortality actually, but actually healing the ulcer, there's very little evidence. Use of bioengineered skin. This actually, when I was a younger registrar, honestly, in the UK and the US, all the companies were trying to sell this bioengineered skin. It's kind of gone out of fashion now because people have realized it doesn't really work. Offloading, whether or not that helps. Honey, so there's a lot of been written about honey. Hyperbaric oxygen. Again, there is limited evidence, and actually the evidence that hyperbaric oxygen works is only in people who have got established peripheral vascular disease, right? Not in people that just come in with a foot ulcer. And then negative pressure, this is wound pressure. So which of this is actually has got some evidence? Actually, all of those disappear. Offloading, there is evidence that it will help. Debridement, there is evidence that. Hyperbaric oxygen, again, only in people with established peripheral vascular disease and negative pressure. So here's the first of the dogmas that I want to kind of address, which is that if we have a population of people with diabetes or diabetic neuropathy, what we do is we diagnose sensory loss using these instruments: neurological examination, monofilament, or biothesiometry. Okay? We then identify these high-risk patients. So a 10-gram monofilament, in sensitivity to the 10-gram monofilament, will tell me that a patient has got advanced neuropathy. Okay? So I then do that and I say, okay, you're in this group. You're a high-risk individual. Or if I do biothesiometry and it's over 25 volts on the biothesiometry, I will say, this is high risk. So then the logic tells you that if you take these high-risk individuals and you sit with them and you tell them, you know, you are at high risk of having a foot ulcer, you need to take measures to prevent this ulcer, which is wear appropriate footwear, look at your feet every day. It will prevent people from having an ulcer or an amputation. What's the evidence? Well, actually, the evidence isn't there. And there are many people go around the world and talk about, you know, doing this. But in fact, if you look at the evidence, and this is, again, one is a Cochrane Review, but there are other studies as well, it shows that there are 5 out of 12 randomized, there are only 12 randomized control trials, 5 of them effective patient education on prevention of foot ulcers. 3 studies demonstrated no benefit out of these 5. There are only 2 studies that really looked at this. In 1989, there was a very small study from Malone, from Miami, which actually showed a benefit. But now we read this study, we see that it was extreme bias in this study, in the way they recruited into the study. The only, I think, worthwhile study is this 2008 randomized control study from Nottingham in the UK, which did not, in fact, confirm that education will reduce your risk of amputation. And in fact, if you look at the figures, you can see here relative risk of amputation changed 0.98. What does that tell you? What does 0.98 figure tell you? 2% reduction in risk, which is, you may as well not bother. Okay? The problem, I believe, in the management of the diabetic foot is this. It is a thing that we address far too late, right? Because the horse has already bolted, right? People present to you with a foot ulcer, and these people are actually sick from cardiovascular point of view, from every kind of way you can think of, and they are high-risk individuals. So I think it's really, and this is actually one way of looking at it, which is the 5-year mortality figures for people with a diabetic foot ulcer. Why do I put a 5-year mortality figure up? Because standard way of looking at 5-year mortality is to relate it to cancer. Yeah? So people often think about cancer as being this terrible disease, illness, which you get, you're dead with, majority of people will die within 5 years. So let's look at the figures. Here's the 5-year mortality figure for prostate cancer, 8%. Breast cancer, 18%. Hodgkin's lymphoma, 18%. Neuropathic diabetic foot ulcer, neuropathic, not even ischemic, 46%. Next to it, amputation, 40%. Colon cancer, 48%. Ischemic diabetic foot ulcer, which is what we'll actually present to you guys, is 66%, right? And then you can see these other, lung cancer is much higher and pancreatic cancer. But you can see that, having a neuropathic foot ulcer or a neuroischemic ulcer he's actually got a huge mortality. And that, is, I think, is an issue that we have to address. And this is data that was published in 2007, but there's a more recent data set published in Diabetic Medicine from 500,000 people. Again, confirms this 42.2% 5-year mortality for a person with a neuropathic foot ulcer. So here's a case. 64-year-old male, type 2 for 25 years. It's had retinopathy with previous panretinal photocoagulation, hypertension, EGFR, you can see moderately impaired renal function. And he presents with an ulcer and swelling for about 2 months. And actually went to 2-3 different, went to his primary care physician, went to another physician, went to another physician. And you know what they did for this? What's the standard? You kind of look at it, you say it's not red, hasn't got a temperature, his white cell count is up, put another bandage on, come back in a week's time. You don't really do much, okay? So here's his investigations though. Eventually when he turned up after about 2 months, ESR is 80, CRP is 142, and the procalcitonin is 4.6, right? Now, do you do procalcitonins? Do you know what procalcitonin is? Kind of, yeah, it is. But it's actually more infection than inflammation. But to me, these are the standard markers, and these clearly tell you that there's something not right with this patient. But I'm going to talk to you about this. This is actually, I think, is not a promising, but it's been around for a long time in ITU, but we don't use it, I don't think, in the world of the diabetic foot. So what's the diagnosis in this patient? Remember the picture? Has he got cellulitis? Has he got melanoma? Has he got gout? Has he got Charcot? Has he got osteomyelitis? Yeah, you kind of have to think about osteomyelitis because this is looks actually, if you look at it, that to me, you could say, well, is it really osteomyelitis? Superficial. But actually, you go down, you probe down. If you put a probe in here, you'll see it'll hit bone. And that's one of the other things you do. Okay. So here is I guess the benefits of looking at procalcitonin. So there are 3 independent studies that are being done using procalcitonin. And this is how, so to me, if I go back here, the big difficulty is I could do an X-ray and I could look, plain X-ray, and see if there's bone destruction. But often you don't see it, right? I could do an MR, which is actually does show early osteomyelitic change. But often the difficulty is in deciding, is it osteomyelitis or isn't it? So here's how you can use procalcitonin to help you. And unlike these things have to be really high. So actually in this case, you would be able to differentiate DFU from osteomyelitis. Why? Because what was the ESR in this patient? 80, so it's over 67. So that's a good, that's a diagnostic cutoff with a high sensitivity and specificity. CRP, what was it? 1. Yeah, so that definitely fulfills the ground. Procalcitonin, 0.3, greater than 0.3, has actually a sensitivity specificity comparable to these. And what was the procalcitonin? 1.4 something, I can't remember, or 4 point something. Okay, so that's easy, I think, in differentiating. But here's another study, actually, that challenges this study. Here, actually, they took a cohort of, this is a more recent study, patients with osteomyelitis and a diabetic foot ulcer. And actually, they showed that ESR, CRP, IL-6, IL, no difference between those with osteomyelitis and DFU. The only thing that differed is procalcitonin. Therefore, arguing that procalcitonin maybe is a better marker of osteomyelitis than the other markers. And then there's a more recent study actually just published where they took 156 patients who they looked at who were admitted with a foot ulcer, and then subsequently they followed them up to see what happened to them. And there were a group that had no amputation and a group that went on to have an above knee or a below knee amputation. And what they found is that the only marker that differentiated these people who had an amputation compared to those who didn't was procalcitonin. So it actually almost prognostic of a bad outcome. And that to me says the reason why these people had AKA, BKA is because they actually had underlying osteomyelitis, which wasn't healing, which wasn't adequately treated, and then it progressed. And that's why they had this amputation. Okay. So what is procalcitonin? Actually, it's nothing to do with bone. Right? You might think because the osteomyelitis, bone, calcitonin, it has nothing to do with that. It's in fact, procalcitonin is however, a precursor of the hormone calcitonin, right? But this is where it actually, its basis, its molecular basis is. So it actually is raised in sepsis. Bacterial toxins in particular, so not necessarily just inflammation, but it has to be inflammation as a consequence of infection. Bacterial toxins, whether they're gram-positive or gram-negative, and cytokines as a consequence of this, actually stimulate the production of procalcitonin. Not from up here, right, but actually in other tissues. So, for example, we know in the normal production of calcitonin is from the thyroidal C cells, but what happens here is that there is calcium triggers the release of this, but then the procalcitonin actually gets packaged into Golgi apparatus, and it stays there until you need it to be released, okay? And that's how it works, calcitonin works. But when you have inflammation, infection, what happens is in a variety of cells, and this is just an adipocyte, but in a variety of cells, these triggers, whether it's IL-1 beta, TNF, interferon gamma, whether it's an infection, will all cause the production of procalcitonin in different cells. And actually in this situation, what happens is they don't get packaged and wait until they need to be released, but they just get released straight away into the circulation. So if you do that, then you can see that you actually get constant release of this, and if you can detect it in the circulation. Okay, so which test should you use to identify a patient with osteomyelitis? So this is a patient, right? He's sitting there, and you can see actually this kind of looks like a superficial wound. But I'm telling you there's underlying osteomyelitis. So what test would you use? What would be the best test? MRI? Yeah. Clinically, probe to bone, right? So sometimes, you know, as physicians, we tend to we don't do things. So honestly, get a probe, stick it into the wound, right? And if it starts to hit bone, that's a high probability. And it's actually been shown time and time again that that is a good way to do it. Of course, that's not diagnostic, and you shouldn't say, okay, that's all I need to do. But if it does that, then it should mean that you should do the next step, which is a plain X-ray, actually. And if the plain X-ray doesn't show anything, then an MR, right? So this is actually, I mean, of course, you have bone scan and CT, which can also show you that. So imaging, so this is the wound, and what you're trying to identify is alterations actually underlying it in the bone, right? And that you can probe, and if you hit bone, it's likely that it's going to be high risk, high sensitivity, not so much specificity actually, but for osteomyelitis. Then, of course, you can do an X-ray, and in obvious osteomyelitis, it's easy. But I can tell you, I've seen plenty of people who've got good going osteomyelitis on MR, and they've got nothing on their plain X-ray. So it's often not good just to say, okay, you know what, I can probe to bone, the X-ray looks normal, so you haven't got osteomyelitis. It's always, if you have a suspicion, do an MR. An MR actually will show you, look, you see here, there's a superficial wound here, and you can see there are changes that you can see on different sequences, and our good colleague, Dr. Sadat, will be able to tell you what the difference is between STIR sequences and T1 sequences. I don't have a clue. Okay, so which test has got the best sensitivity and specificity? So this is actually a review, meta-analysis that's been done to diagnose osteomyelitis, how the tests stack up. So you have actually got 4 trials for plain film. Sensitivity 54%, specificity 68%. So kind of in the middle, okay? MR, 90% sensitivity, 79% specificity. And then you've got bone scan and probing to bone. You see probe to bone, 60%, but 91% specificity. To me, if I want to exclude a condition, I want high specificity. If I want to make, not miss it, I want high. So actually probing to bone is pretty good if you want to make sure that, that you're not missing something. Okay. So once you've got a wound, what should you use as an antibiotic? That's the next question, often. But actually, you know what? It doesn't really matter. People come along and give you you should use this or that. What you have to think about is that and this is the latest guidance actually, Ben Lipsky, the IWGDF guidelines, antibiotic treatment is empirical initially to cover gram-positive, gram-negative, anaerobes, and pseudomonas, which in a foot wound is going to be there, right? It's a messy wound. You have a choice of cephalosporins, penicillin-based carbapenems. And actually, if you think there is ongoing osteomyelitis, then you should think about clindamycin with ciprofloxacin. There are also, be aware now, actually, on the market, topical antimicrobial peptides as well. So these are actually sponges, gentamicin sponge, pexiganan. And there was a vogue for a time where we, in Manchester actually, when we thought somebody had osteomyelitis, that it was deep, we would get these gentamicin impregnated beads and put them into the wound. Some evidence that they work, but what the key thing to remember is how long you put people on antibiotics for. If you think this is a mild infection, then you need to give it for 1 to 2 weeks. If you think it's more serious, 3 weeks. If it's osteomyelitis, then actually it's very different. In osteomyelitis, if you say, I think this is osteomyelitis based on X-ray or MR imaging, and you send them to the surgeon and they remove that piece of bone, okay, then your antibiotics, actually, you only need 1 week of antibiotics. However, if you contemplate doing it without removing that bone, then actually you should have antibiotics for a minimum of 6 up to 12 weeks. And that's important because often people say, oh, it looks better superficially, and they stop the antibiotics. And really you need to give it 6 to 12 weeks. And the standard, actually, the antibiotics that I would give is Cipro and Clinda. Here's case 2, 45-year-old male, type 1, EGFR 38, swelling of the right foot, CRP is 2, ESR is 5, procalcitonin is 0.1. What do you think is going on? Okay. Imaging. X-ray shows what? So actually what it shows is there's no real disruption of the bony surfaces. This is, I mean, you can see there are changes. This is not osteomyelitic. And in this sequence you can see here. So this is often, actually, very often misdiagnosed as cellulitis, osteomyelitis, gout. How often have I seen persons not yet familiar with this arthropathy forget that behind the disease of the joint there was a disease far more important in character and which really dominated the situation. And the disease that Charcot was talking about was actually Charcot actually originally described in syphilis, but telling you that this is neuropathy is the underlying background of all this. And really, even the latest kind of causes are not fully understood. So what's the pathogenesis of Charcot foot? What causes it? Well, actually, what we believe is that there is sensory loss, large and small fiber, and there's an increasing, actually, bit of evidence to say that small fibers are probably more important than large fibers. So it's not just sensory loss that then allows the patient to injure themselves. And then, as a consequence of that, you get changes in the bone itself. And for a long time, actually, we've focused on the osteoclasts through this pathway, which is an inflammatory pathway, the Rankel pathway, which alters osteoclastic function and causes bone lysis. So this is osteoclasts. Remember, osteoclasts break down bone, osteoblasts build bone. So we've believed that it's predominantly osteoclastic abnormalities. But there is now evidence to suggest, actually, that there is osteoblastic dysfunction as well through a separate pathway, which is actually the Wnt-B-catenin pathway, which is actually, it is part of the, if you look at an X-ray or an MR scan of a patient with the Charcot, they don't just get dissolution, they get this new bone that forms. And in addition to that, actually, there is also now evidence that there is probably very early, before even bone problems, there is loss of CGRP nerve peptides and small nerves around the capsule of the midfoot. So you get weakness, and that's why you get dislocation. So what is elevated in Charcot? CRP? No. ESR? White cell count? Procalcitonin? No. None of these. So can you use any of these as a way of helping you when you see a patient with a Charcot? What do you use? How do you diagnose it? No. Actually, it's the thing in front of you. You need to be looking. One of the key things actually is history. Was there some kind of injury? Did they fall? And then actually a lot of people before have said you can use some of these markers, but the evidence is that there's actually no rise in CRP or ESR or white cell count in people with Charcot. This is 36 consecutive patients from King's College that looked at, and one of the other key differences actually is this, skin temperature. If you have a patient who's got no obvious wound, right, and they have a difference in skin temperature of 2 degrees from one foot and the other foot, actually has high risk Charcot, obviously in the context of diabetes and severe neuropathy. Imaging, MRI has a sensitivity of 76%, specificity of 75%, but this is something that people are, one study was amazing, this one, showed that you know, if you use FDG PET, you had a sensitivity of 100% and a specificity of 93%, but there's been a subsequent study actually that shows not quite as good. So the sensitivity was down to about 90%, but the specificity still remained. So that's something you need to think about as an alternative if it's available. So the diagnosis in this condition is Charcot. Management of Charcot, how do you manage it? What's the best way? Bisphosphonates, calcitonin, surgery, denosumab, teriparatide. Sorry? Bisphosphonates? Offloading, good. So in fact, so surgery in the right setting, surgery I always used to use in the UK certainly when we had a patient with a rocker bottom foot from Charcot. You can actually get very good foot surgeons can slice the bone and make the foot kind of straight, and that's actually what you want because you want to prevent them from getting an ulcer, recurrent ulcer. So offloading, yes. For sure, but again, offloading not for a month when this patient starts feeling better, but offloading for up to 6 to 9 months has been shown to be beneficial. And if a remission, actually, one of the key characteristics we use is a temperature difference of less than 2 degrees. Okay? Here I'll finish off with a few other cases which I think we get caught out, right? So this is actually just another ulcer, I call it. So this is not my case, but I've got a case. This is actually an 80-year-old Bedouin male, type 2 diabetic, on insulin, 4-year history of an ulcer. All right? And I'm sure you see them, I see them here, I'm starting to see them here because they just don't come to the doctor. Initially had a coin-sized lesion with rapid growth in the last 12 months. And the reason why he'd not come to the doctor is his fear of amputation. He thought, I've got this, they're going to amputate. But this is how he presented. What do you think is a diagnosis? Potentially. So let me tell you. So this is the X-ray. Exuberant growth. Maybe some involvement of the bone in there. Is that osteomyelitis? Could be. But, so actually what he had was, and PET-CT confirmed this, he had widespread Mets. He actually had a nodular melanoma. And you think normally melanomas are kind of on the upper extremity, but they're not. In fact, melanomas 30% occur in the lower limb and 3 to 15% in the foot. And it's really important that you're aware that, you know, not every lesion in a patient with diabetes is necessarily just a foot ulcer or osteomyelitis. This is actually a case when I first started as a consultant in Manchester that we had, and so this is you know, you say, okay, this happens here, but this is what happened in Manchester. 48-year-old male, type 2. Actually, he'd been coming to the clinic under, I daren't say it, Professor Bolton for the last 18 months. And people have just been seeing this guy and debriding his ulcer and going. And I started as a new consultant, and I looked at this and I thought, this is strange, you know, why is it this guy's not healing his ulcer? And then actually, because I used to do internal medicine, right? So at the time I used to be, you know, I didn't just look at the foot. So I examined this guy and, you know, I found he had some lymphadenopathy, right? And this was his ulcer. You can see, you might say, well, this is just a neuropathic ulcer, right? But we did a biopsy. This was the H&E stain. What do you think is the diagnosis? And then we did this, S100 and HMB stains. What do you see? Actually, what he had is amelanotic melanoma. So it wasn't typically melanotic melanoma, but it was an amelanotic melanoma. And in fact, CT scan showed he had metastases to inguinal lymph node and liver, and he died 6 months later. So last bit, I know I said honey hasn't got much evidence, but there is, I think, accruing evidence. And this is the most recent study, actually. So it tells you that honey has antibacterial, anti-inflammatory, removes odor, reduces pain, and heals wounds. And in fact, there is a systematic review that was done that shows that there are 6 randomized controlled trials, 546 patients, case series about 317 patients, suggesting that honey may play a role in the healing of wounds. And there is one study actually published in, from Pakistan, originally done in Pakistan by these guys. They then moved to, I think it's Saudi Arabia, and then maybe had a little bit of time on their hands and decided that they need to publish this. So here you can see they've used this particular type of honey from the Qatar region, gamma irradiated, and they essentially, the biggest trial to date actually, is about, I think it's about 200 odd patients. But what they show is that the duration in terms of healing, wound healing in those were treated with honey, 18 days compared to 29 days. And you see here, wounds healed within 120 days, those that were honey treated were significantly better than those that were saline treated, and the non-healed wounds again significantly lower in the honey treated compared to the other group and deterioration. So overall, this is probably the largest trial that shows that there is benefit of honey for wound healing. Yeah. Yeah, locally, onto the wound. And it's actually an amazing, honestly, when I've used it, in the past we used to pay a lot of money because there were companies that produce dressings with honey on them. And one of the things that really, really is striking is how the odor disappears. It's amazing. It's like it's no smell from the wound anymore. But obviously it's osmotic, and there is actually evidence to show it's antibacterial. So you apply it locally. Thank you.